Well, welcome everyone. It is with great pleasure that I welcome you all to the Miriam Lemberg Professorship in Cardiovascular Disease Lecture. So our speaker today is Dr. Nancy Sweitzer. She's the director of the University of Arizona Sarver Heart Center, professor of medicine and chief of the Division of Cardiovascular Medicine at the University of Arizona. She's board certified in advanced heart failure and transplant cardiology. She's also a physician scientist specializing in heart failure, mechanical circulatory support, and heart transplant. She has led and collaborated on clinical trials sponsored by the NIH, as well as industry, foundation, and academic sponsors. She has served on multiple NIH committees and currently serves as a member of the NHLBI Clinical Trial Study Section. She was recently also named to the FDA Advisory Panel on Circulatory Support Devices. Dr. Sweitzer is the editor-in-chief of the Journal of Circulation Heart Failure. She's active in leadership of the AHA, American College of Cardiology, and the Heart Failure Society of America. She's the president-elect of the Association of Professors of Cardiology and was inducted into the Association of University of Cardiologists in 2017. Please join me welcoming Dr. Sweitzer as she gives her talk on saving lives and preventing readmissions with outpatient management of heart failure with reduced ejection fraction.
Thanks, Manuel. I'm checking this. So I am on. Well, it's just a terrific pleasure to be here. I'm going to start with my disclosures just so everyone knows them, but then really begin with thanks to the Lemberg family. Being invited here was just an amazing honor, and learning this morning of all the amazing things happening at the University of Miami, particularly around multidisciplinary research, has been a real treat. Miami and Arizona share a partnership in something called the Eureka Institute for Translational Medicine, where I have been faculty, and I see some of the alumni here, and that's been also a real treat. Learning about Miriam Lemberg and her husband, Louis Lemberg, it was really probably the primary pleasure of my preparation for this talk. These two obviously had enormous mutual admiration and respect and love, and that was expressed philanthropically to the Miller School of Medicine, which is, an incredibly special gift. And I think that all such gifts are in large part borne out by a physician who's incredibly not only kind and compassionate, but a good communicator, invested in the patient-doctor relationship and healing. And so I use those as touchstones as I go forward, and I hope I can share with you some of my clinical knowledge and accumulated wisdom and leave you with something actionable at the end of the day. So I'm going to start with a case. This is a 62-year-old woman. She has coronary disease, had an MI and stent 10 years ago, and presents to your clinic for regular follow-up. Very fatigued, short of breath with light housework. She's quite inactive and lightheaded, bending over. Her blood pressure is on the low side. Her pulse is normal. She has elevated jugular venous pressure, but a clear chest, no edema, a holosystolic murmur, and an S3 gallop, and an enlarged liver with hepatojugular reflux. So, no surprise, we have a case of heart failure. She's on aspirin, atorvastatin, and carvedilol, and she follows her low-fat diabetic diet, but because it's unpalatable, she uses salt for flavor, and she drinks lots of water for her health and to flush her kidneys, and fills her 32-ounce water bottle multiple times a day. So we're going to talk about the epidemiology of heart failure with reduced ejection fraction in a framework. We're going to talk about diagnosing and treating volume overload, because I think this is a particularly important skill to develop. We're going to talk about heart failure trials to date in a whirlwind overview, and then optimization of the patient with heart failure and reduced ejection fraction. So this is already a huge problem, but it's going to become a much greater problem. In the next 10 years, as the baby boomers continue to age, we're going to see an enormous increase in heart failure, 8 million new cases by 2030. It's already the leading cause of hospitalization in patients over age 65, and that's only going to grow. For all of you interested in pursuing cardiology, we have job security. This figure shows in the blue lines the death rate from heart failure, both accrued rate and an adjusted rate, and it's going down slightly, but going down. But the problem is the green line, which is the absolute number of deaths, and that's going to grow very rapidly because of the increased prevalence of the disease. And so even though the rate per 100,000 people is going down, more of those 100,000 people have heart failure, and the absolute rate's going to go up. So this is a huge problem. Now, what I'm going to talk about largely in this talk is something called optimization. And I talk about this a lot with my patients, with referring physicians, and with my colleagues, we talk a lot about patients being compensated with heart failure, but I would argue that compensated is not optimized. To optimize a heart failure patient, polypharmacy is obligatory, and many clinic visits are necessary, and you have to come to peace with that as a practitioner treating these patients. It's really important to honestly assess a patient's ability to self-manage. A lot of what we ask of patients in the heart failure space requires enormous ability to self-manage. And I sat next to a really smart nurse practitioner once on a panel who said, we have three kinds of patients. We have born self-managers, and you've all seen them, right? They bring their logs to clinic, and they've got everything written down 4 times a day, every day for the last 3 months for you. We have the teachable self-managers, where you tell them what they need to do, and they'll do it. And then you have the never self-managers, and I'm sure you all know some of those. And she said, within 20 minutes of meeting a patient, you know what you have. And she said, if you have a never self-manager, don't give them a 20-minute lecture on salt and fluid, because it's not going to work. What you have to do is start working with that patient's surrounding infrastructure. What's their support system? Who can we enlist to help that patient self-manage? Because they're not going to be able to do it on their own. The ability at the bedside to assess volume status and perfusion are critical to optimization, and we're going to talk a little bit about physical exam here. And then for those of you who are in primary care, find ideally a heart failure specialist partner or a cardiologist who likes heart failure to partner with in these patients, because they're complicated, they require lots of touches, and sometimes just saying, you know, I'm getting a little uncomfortable here because we're doing a lot of advanced therapy, and I'm going to bring in this partner of mine who's going to help us get you really to the point where your disease is as good as it can be and your life is as good as it can be. And that therapeutic relationship between a primary care doctor, a specialist specializing in chronic disease, and a patient can really be transformational for some of these patients. So this is in graphical form my schema. We have heart failure patients with reduced ejection fraction who are symptomatic and asymptomatic. And we're going to focus on the symptomatic patients, and that means they've ever had a symptom of heart failure. And we're going to talk about not the acute symptomatic patient, but the chronically symptomatic patient. And we divide those into the compensated patients and the decompensated patients. And the compensated patients come to your clinic and they're not complaining of anything that needs intervention urgently. But the compensated patients can be divided into optimized and not optimized. And the reason that this is so important is it's the not optimized patients who do that, who end up decompensating because of some other additional stress and to be hospitalized. And the driver of cost in this disease is largely hospitalization, unplanned hospitalizations, unplanned clinic visits. And so if you can prevent that from happening, you will have an impact not only on the health economics of the disease, but on your patients' lives. So I'm going to direct you multiple times during this talk to this document. It was published in the Journal of the American College of Cardiology at the end of 2017, and it's an expert consensus decision pathway for optimization of heart failure treatment. So it's exactly what I'm talking about, and it's 10 pivotal issues about heart failure with reduced ejection fraction, and you can't see all these, but I'm going to highlight some of them toward the end of the talk. You know, when to refer to a heart failure specialist, how to address challenges of care coordination, how to improve adherence. These are really important practical issues that are outlined in this document. It's really a nice document. So the guidelines for heart failure with reduced ejection fraction are complex and involve lots of therapies. At the base of the pyramid here are the angiotensin blocking therapies, beta blockers, and mineralocorticoid receptor antagonists, the backbone of the therapy. And the reason polypharmacy is essential because each of these classes of agents has been shown to save lives when added to the other classes. So you can't get away with one of them. And then on top of that, we have all our device therapies that we use in cardiology in select populations of heart failure with reduced ejection fraction patients. All of these have been shown to be life-saving. And then around the edges, we have some other therapies that have some benefit in select populations. But what's not on here, and what is I consider the backbone of our therapy, are diuretics. So we're going to talk first about diuretic therapy in heart failure, because no one ever talks about diuretic therapy in heart failure because there are no trials, and there never will be a trial. You can't randomize someone to no diuretic when they're in heart failure. But diuretics produce symptomatic benefits, as you know, more rapidly than any other drug in heart failure. They cannot be used in isolation, but they're the only drug that adequately controls fluid retention. They should not be used alone in the treatment of heart failure. And this quote is from the original heart failure guidelines that were published in 2003. It's not in the guidelines anymore, but I think it's completely true. As a heart failure specialist, I don't see people failing to put patients on angiotensin blocking drugs or beta blockers, but I see inadequately diuresed patients all the time. So optimal use of diuretics is the cornerstone of a successful approach to treatment of heart failure, and being able to use diuretics appropriately and comfortably use them, often in very high doses, often in a patient with abnormal renal function, is really critical to optimizing these patients. So in many medical schools, including the one I went to, and in many halls in many respected hospitals, including the one I work in, you often hear people talking about these patients and filling pressures and saying, you know, it's a big dilated heart, and if you don't have them on the high side of the Starling curve with high preload, they'll suffer lower cardiac output. It's common fallacy in medicine, and it's a fallacy. These are data from 1986, so not new, in which this is from UCLA, and they took patients admitted with acute decompensated heart failure, and they put in pulmonary artery catheters, and they all had very high filling pressures, wedges up in the 20 and 30 range. And they looked at the stroke volume, the forward stroke volume at those filling pressures, and then they applied therapy of acute decompensated heart failure in 1986, which included diuretics, and in most of these patients, vasodilators. The original ACE inhibitor trials were just coming out, and the attention to afterload was starting to increase. And so these patients got vasodilators and diuretics, and what you saw is that as their filling pressures lowered, stroke volume went up. And it went up continued to go up and plateaued at very normal filling pressures, wedges of 8 to 10 millimeters of mercury. So not elevated, they didn't need excess preload, they had normal preload that you and I all have, hopefully, and that still maximized cardiac output. So that's the first thing that's really important to realize, is that these patients need normal filling pressures on the left. Sometimes you can't achieve that in a given patient, but you want to try as hard as you can to get there. So in order to assess volume status, you have to be able to assess jugular venous pressure. And all medical students, including those at the University of Miami, I'm sure, are told to lie your patient down to 45 degrees, and then the clavicle is 5 centimeters above the right atrium, right? You all know this drill. So what I'm going to tell you, and this is a published article, is don't assess your heart failure patients at 45 degrees. Assess them at 90 degrees, sitting bolt upright. When you're sitting bolt upright, the right atrium is approximately 10 centimeters below the clavicle. So if you see jugular venous pulsations in a patient who's upright, they have elevated JVP. You're done. And I don't really care what the number is. It's just elevated, and you need to diurese that patient. The really interesting thing is, in a decompensated heart failure patient who can have right atrial pressures in excess of 20, 25 millimeters of mercury, if you lie them down at 45 degrees, often that neck vein's so full that you don't see anything. You lose the pulsations. So I encourage you to examine the patients you suspect are in heart failure sitting up. If you cannot see the jugular venous pulsation sitting up, then you lie the patient down, and you lie them down until they're flat. And if they're flat and you still can't see a neck vein, then you can say that patient's neck is not evaluable. But I doubt very many people have ever done that. And the dirty little secret in my world is that when patients have excess adipose tissue and very thick necks, the JVP is actually quite easy to evaluate. That subcutaneous tissue vibrates with the jugular veins, and you can tell that it's elevated pretty easily. What I don't like are elderly women with thin, ropey necks. They're very hard to evaluate, I think. So it's actually the body habitus that gets written in the chart as not evaluable all the time that's most easy to evaluate if you know what you're doing. Examine both sides of the neck. We're taught to use the right because it's a straighter shot, but sometimes the left is just easier to see in a patient, and it's okay to use it. If you can see it on that side, it works. If you can only see the external jugular, which sometimes you can, if there are respirophasic changes in that with quiet breathing, so it's reflecting the changes in intrathoracic pressure, that tells you there's no valve impeding flow, and you can use the EJ. And then we won't talk about inferior compression. But this is published work, and this is what I do in my practice. So you've looked at the patient's neck, bolt upright, you've determined that JVP is elevated, and you need to diurese the patient. So when do you know you've reached the limits of diuresis? Well, ideally, that should see JVP less than 8. They have no edema, they have a JVP less than 8, and they have a good exercise tolerance. So a patient is optimized when they're really dry. Having a little edema is not okay if it's due to heart failure. Sometimes people have edema due to, venous insufficiency and problems in the venous system, and that's a different ballgame, probably not harmful, if their filling pressures are normal. Now, one of the things that limits diuresis in heart failure patients all the time, right, is the rise in creatinine that we see. And indeed, the creatinine often rises as we treat volume overload, when we treat it this aggressively. Sometimes that rise in creatinine suggests that afterload reduction is needed. We're going to talk a little bit more about that. But there's been a lot of attention to this in the heart failure space over the last couple of years, and it's very clear that creatinines that rise during diuresis for acute heart failure are not associated with worse outcome. And what I tell people is if you let your patient run around volume overloaded to keep their creatinine normal, you're only fooling yourself. That creatinine's not normal, and it's not normal when they're wet, and it's not normal when they're dry. You just can't, you don't notice it as much when they're wet because it artificially lowers the creatinine, but they still have renal dysfunction. And so sometimes the creatinine goes up, and that's okay. So Lasix is the loop diuretic, of course, that everyone's quite familiar with and uses a lot. Orally, Lasix doesn't work very well when you start to decompensate. When you have gut edema, fluid in the belly, the oral bioavailability of Lasix is quite poor. In a healthy, normal person with no gut edema, Lasix is 50% orally bioavailable. That's why you dose it with half as much IV, right? But when you start to put edema in the gut, that oral bioavailability goes down to like 10%. And I frequently get calls from patients who say, yeah, my weight's up 5 pounds and my Lasix stopped working. So they're telling me my oral bioavailability of Lasix has gone down and I need something else. So the other alternate loop diuretics are bumetanide, which you're all probably quite familiar with, and torsemide, which many of you probably aren't familiar with. Bumetanide, there's very little data comparing it to furosemide. We don't really know. It does have renally cleared a metabolism, and that's probably not a great thing in heart failure patients, but it is more orally bioavailable in heart failure. But the companies spent a lot of money on advertising and not a lot of money on research, which makes me fairly negative about it. Torsemide, on the other hand, the one you've never heard of, that company spends their money on research and not on advertising. But torsemide has been shown in multiple small studies to be superior to Lasix in heart failure patients with volume overload. It's more bioavailable, it's cleared hepatically, which can be an advantage, and and it works better in managing outpatients who are struggling, particularly with gut edema or right-sided symptoms. There is an NIH-sponsored trial underway, enrolling quite well. I think they're about a third of the way through enrollment. 2,000 patients leaving the hospital after a hospitalization for heart failure, randomized to either oral torsemide or oral furosemide. So we'll have an answer to this question, but I encourage you to get to know furosemide if you have a substantial, or sorry, get to know torsemide if you have a substantial heart failure population. So I want to go back to this issue of afterload. So this is my hand-drawn on the computer diagram of a big dilated heart with systolic dysfunction. And when that heart squeezes its poor little systolic contraction, the blood can go two ways, right? It can go forward out the aorta, which is what you want, but it can also go backwards through the mitral valve as mitral regurgitation. And most of these hearts, when they're dilated with high filling pressures, there's a substantial amount of backward flow and mitral regurgitation. So this is the idea of why when you diurese and afterload reduce a patient, their stroke volume can go up. If you afterload reduce them and optimize the conditions for forward flow out to the systemic circulation, you can have redistribution of flow. Systolic function and stroke volume haven't really changed, but effective forward stroke volume is optimized by afterload reduction. And also by diuresis with reduction of wall stress in that heart. There's probably less MR and more forward flow. But the combination of reducing afterload, if you have blood pressure to do it, with diuresis is incredibly effective. And what you'll see then is a patient who presents with renal insufficiency and heart failure, who, as you diurese them, has improvement in renal function, and you've probably all seen that happen. So this is my favorite call from the ER, right? My patients in the ER short of breath or feeling unwell, and they've assessed my patient who has no edema, no RALs, the chest x-ray is negative, and the creatinine's elevated, so they're giving him fluid. I get that call all the time. Please don't give my patients fluid. Yeah, and they couldn't evaluate the JVP due to body habitus, right? So my patients almost never need fluid. What's the issue in these patients? There is arterial hypovolemia, right? Their creatinine often looks pre-renal. There is venous hypervolemia. You got to be able to evaluate the neck veins to know that, right? So the volume is maldistributed, and the problem is where? It's between the veins and the arteries, which is the heart, right? The problem is the heart. We need to treat the heart. We don't need to give fluid to the kidneys. If you treat the heart and you optimize the heart, the kidneys will be optimized. They may not be normal, but they'll be as good as you can get them. Okay, so we're going to move off physical exam for a bit, and we're going to talk about the history of clinical trials in heart failure. I do like to talk about diuretics first, because when the patient comes into the emergency room, they never say, my angiotensin levels are really high, right? They say, I'm short of breath. And you need to do the diuretics to get the shortness of breath to go away. But if you don't block the angiotensin system, which is very high in many of these patients, you will not optimize your patient either. So once you've volume optimized your patient, then you need to get them on the appropriate therapy. So these are pivotal trials in heart failure. The Consensus 1 trial, which looked at enalapril versus placebo, and the Solved trial, also enalapril versus placebo. Consensus 1 was done in the era when nothing else was done for heart failure patients other than DIG and diuretics. And Consensus 1, you can see this, over 12 months, the placebo arm had a mortality of 60%. These were patients who were not doing well. And enalapril reduced that mortality by 40%, and the number needed to treat was 6 for 6 months to save a life. That's a pretty good deal. Solved, similarly, the patients were a little less ill in Solved. The placebo mortality was 40%, but over 4 years, so not nearly as sick, but still a 16% reduction and a number needed to treat of 22 for 2 years to save a life. Those are pretty impressive data. I put these up here for contrast with the ARB trials, VALHEFT, which tested valsartan, and CHARM, which tested candesartan, in patients intolerant to ACE inhibitors because of cough or other side effects. And VALHEFT showed improved survival with valsartan event-free survival, but this was primarily due to a reduction in hospitalization. There was actually not a mortality difference in Valheft. And that's important to know. ARBs are not as good as ACE inhibitors in this population. And the reason that the heart failure doctors get very dogmatic about starting ACE inhibitors are these data. Similarly, in CHARM intolerant, the reduction was in CV death or admission for heart failure, and it was a substantial reduction with a number needed to treat of 28 for greater than 2 years, but the impact on mortality was quite small. And so it's important to realize that when you're putting your patient on an ARB alone, that it's probably less effective than an ACE inhibitor in terms of mortality outcomes. Not ineffective, but not optimal. We have a new drug to deal with that, and I'll talk more about the paradigm results toward the end of the talk. I think this is just beautiful, an electron micrograph of epinephrine. So we'll talk about beta blockers. Similarly, the US carvedilol trial, a quite well population. The placebo mortality was 10% at a year, but carvedilol reduced that strikingly, and the number needed to treat is 21 for 1 year. The patients enrolled in the US carvedilol trial were very well because we were really worried we were going to kill people with beta blockers. You're taking patients with systolic dysfunction and inhibiting inotropy, and that seemed like a bad idea. But of course, now that we understand neurohormonal blockade, this works very well. And the other thing that was notable in the carvedilol trial was that the majority of the benefit was in prevention of progressive heart failure. People thought if these drugs worked, it was because they reduced sudden death and MI, which they do, but really reducing progressive heart failure. And you all know now when you give these patients beta blockers, many of them have improvement in systolic function because bathing the heart in adrenaline is a toxic thing that leads to progressive systolic dysfunction. We went on to do Copernicus, which was a much sicker population. This group has about a 25% mortality at 1 year, and there was a 35% reduction in heart failure hospitalization or death, number needed to treat 14 for a year. And then in Merit, patients with a 25% mortality over 18 months, which was reduced almost 40% by long-acting metoprolol, number needed to treat 28 for a year to prevent a death. So obviously, you can't withhold either of these medications from your patients. You got to give them at least 2 medications. This, I think, is one of the most interesting and under-recognized analyses out there. The Merit investigators looked at patients over 65 enrolled in the trial and whether medication needed to be discontinued. Remember, this was blinded, and so you didn't know what your patient was on. And you look at this list of things that commonly get attributed to beta blockers, right? Depression, AV block, dizziness, fatigue, bronchospasm, COPD. These are things that we blame on the beta blockers a lot. And if you look, none of them were significantly different between the two groups. And the rates of discontinuation for any of these are super low. Discontinuation for depression was 0.1% in the metoprolol arm in an elderly subgroup. So we blame a lot of stuff on beta blockers because it happens and they're on a beta blocker. But I think if you don't know what pill you're giving the patient, you rarely need to stop for these things. And it's probably not the beta blocker. And in a true HFrEF population, they feel so much better on these medications that they tend to be less depressed, less fatigued, less hypotensive, I find. All right, the mineralocorticoid receptor antagonists. The first trial was the RALS trial. Again, an extremely sick patient population. They have a 50% mortality at 3 years, essentially, and a 25% increase in survival, 27 for 1 year of therapy to save a life. They were very sick patients, so then we went on to do the Emphasis trial, which was eplerenone, another mineralocorticoid receptor antagonist, in mild heart failure. And these were less ill patients, New York Heart Association class 2, all of them. They'd all been hospitalized for a cardiovascular cause or had elevated BNP when they got into the trial. And of course, in all mineralocorticoid receptor antagonist trials, patients, when they come in, have to have a potassium less than 5 or a GFR greater than 30. But we didn't ever stop the drugs or even dose reduce them until the potassium got to 5.5 or greater. So we tolerated some hyperkalemia in this trial. Hyperkalemia, when you have low EF, is generally a good thing rather than a bad thing if it's mild, because there's less ventricular arrhythmia. Emphasis was stopped early because of overwhelming benefit. A significant reduction in 25% reduction in hospitalization for heart failure or death compared to placebo, number needed to treat 19. And death alone, number needed to treat 51 for 3 years to prevent a death. So very effective. So again, not a medicine you should withhold from your symptomatic heart failure patients, even mildly symptomatic. Mineralocorticoid receptor antagonist prescriptions in this population in the US run about 25 to 30% of eligible patients. We're very bad at prescribing this medication. So we've had huge progress over the last 25 years. We had our initial ACE inhibitor trials, which showed a 25 to 30% reduction in mortality. We added beta blockers and got another 20%. And then we added mineralocorticoid receptor antagonists and got another 10 to 15%. And we've had a huge impact. Nevertheless, these patients continue to suffer very high mortality rates, disease progression. It's not like when I started. When I started, I used to tell people probably about a 30% chance of stabilization, 30% chance of worsening, 30% chance of improvement. Recent data suggests that 70% of HFrEF patients will have improvement on this triple drug regimen. So that's, not insubstantial, but there's still that 30% who don't improve and worsen. Which brings me to some of our more recent trials. Paradigm actually isn't that recent anymore. It's almost 5 years old. But it's not a very prescribed drug, so we're going to talk about that. So Paradigm tested a combination ARB, valsartan, and neprilysin inhibitor, sacubitril, head-to-head against enalapril. So this was a trial with an active control. And if we look at mechanistically, so we have the ARB, which blocks angiotensin II binding to its receptor down here, but it also inhibits neprilysin, and neprilysin is an enzyme that lines the vasculature and breaks down a number of small peptides, including the natriuretic peptides, which will go up when your patients are on these drugs. It also prevents breakdown of bradykinin, substance P, and some forms of circulating angiotensin. So you end up with a lot of vasodilator substances that are activated and inhibition of this vasoconstrictor substance. So it's a hemodynamically good drug, and it also is a neurohormonal blocker. So the Paradigm trial enrolled class 3 and 4 patients with low ejection fraction. They had to have previously been exposed to an angiotensin blocking drug. And then they had to go through an active run-in phase where they were able to tolerate both drugs for a few weeks before they were randomized, because we didn't want to end up testing a drug in an intention to treat analysis that nobody took. So it was really testing for patients who would tolerate the drug. So there was this run-in period where you got 2 weeks of enalapril, 2 weeks of LCZ696, and then you were randomized 1-to-1. And in the ultimate trial, they had 10,000 patients screened, and 8,400 of them were enrolled, so there was a 10 to 15% dropout rate in the run-in. And then the 8,400 patients enrolled were randomized. There were over 4,000 patients in each arm. Very few lost to follow-up. And these were the primary results. The primary endpoint was death or heart failure hospitalization, hazard ratio of 0.8, P less than 0.001. But in reality, because the numbers in this trial were so big, the p-value here is 0.000000004. Incredibly unlikely to be due to chance because of the huge numbers. And this is important. We'll get back to this. If you look at the effect on death, also a hazard ratio of 0.8, so 20% reduction in death. P-value is 0.00008. Very certain that this is a real effect to reduce death. Similarly, hospitalization for heart failure reduced by 21%, 0.00008. So very, very small p-values. And then finally, death from any cause, which is a much harder bar to hit, reduced by 16%, p-value 0.0009. So really significant reductions in all of these endpoints, even though the graphs don't look that impressive. So the other thing that's impressive about this trial is that the combination sacubitril/valsartan was more effective than enalapril in reducing risk for heart failure hospitalization. We showed that. Incrementally improved symptoms and physical limitation. Better tolerated than enalapril. It was less likely to cause a cough or hyperkalemia or renal impairment, or to be discontinued for an adverse event. There were more discontinuations in the enalapril arm than the LCZ arm. There was more hypotension with LCZ, but it was treated by dose adjustment typically and didn't result in increased discontinuations. And there was, importantly, no risk of serious angioedema, increased risk of that, because when you start combining these things that might elevate bradykinin, you have to worry about that. So if we look at, historically in clinical trials research, we have to have 2 trials that achieve a 0.05 significance to get FDA approval of a drug. And that's because the FDA wants to be pretty statistically certain that this drug is doing what we think it's doing. They don't want to be 95% certain that it's doing it. They want to be more certain. So this table shows if I have 1 trial at a 0.05 significance, I am 95% sure the effect's real. If I have 2 trials at a 0.05 significance, then I'm less than 0.1%. I'm more than 99% sure that that drug is doing what it says. And likewise, if we have 3, 4, or even 5 trials, the statistical certainty that the effect is real gets much, much greater. So where does Paradigm fall? It was equivalent of doing 4 to 5 trials at a 0.05 significance with that level of certainty. And this is why the drug was approved by the FDA with 1 trial. Not because the FDA was like asleep at the wheel that day or because Novartis paid them off. It's because it was overwhelmingly, certainly positive. Similarly, if we just look at effect on cardiovascular death, it's the equivalent of between 2 and 3 trials. So they didn't need to do more than 1 trial to prove the drug works and works as we said. And remember, it was compared to an active arm of enalapril, which we know is incredibly good at reducing death and heart failure. So this is actually, I think, a more impressive trial than people realize. Now I'm going to just tell a story, a personal story. I got asked to do a debate about this drug and its use in heart failure at one of the heart failure meetings. And I honestly, to that point, had never used the drug. Because like everyone else, I was like, how much better is it really? So I thought, well, if I'm going to do the debate, I better get some experience with the drug. So I went and I talked to my nurse practitioners. Because nurse practitioners are wonderful in very many ways. But one of the ways they're wonderful is they follow protocols. They don't trust their clinical judgment, and they don't think they know better than the protocol like doctors do. So the nurses were putting all kinds of patients on these drugs because they said, I've got a persistently class 3 patient on triple drug therapy, and the protocol says I should switch him to sacubitril/valsartan. So I did. And I said, well, what do you think? They said, oh my gosh, it's an amazing drug. Everybody feels better. It's working like crazy. And I thought, that's interesting. I should try using it. So I started prescribing it. I started following the protocol myself and not using my clinical judgment. And the fascinating thing I found, and it's a lesson for all of us physicians in the room, is that the patients I would have predicted would tolerate the drug very poorly do the best on the drug. And, this is supported in the literature, is that the patients we tend to withhold guidelines-based therapy from are the highest risk patients. They're the elderly, they're patients with renal dysfunction, they're the complicated patients. I will tell you, the patients I have who love this drug the most are my octogenarians and my nonagenarians. My really elderly patients love this drug. They feel so much better. And it's probably because I systematically under-medicate them. They complain of something and I don't up-titrate them. But if I give them this combination pill, I'm giving them 2 drugs in one, and they're kind of obligatorily more medicated and more optimized, and they feel well. So I encourage you, if you've not used this drug and you see HFrEF patients, to try it. Now, this is a very recent trial, the Pioneer trial, published in the New England Journal very recently. And This trial I find fascinating. They took almost 900 hospitalized heart failure patients with low EF and elevated BNP, and they did not have to ever have seen an angiotensin blocking drug prior. And in the hospital, they were put on either sacubitril valsartan or enalapril, again, an active control. The primary outcome of the trial was a reduction in BNP, and while NT-proBNP, which you can measure on sacubitril valsartan. If you look at just BNP, it goes up because you're giving them a drug that increases BNP levels. But NT-proBNP fell in the enalapril group, but it fell statistically more in the sacubitril valsartan group. At 8 weeks, this is an 8-week endpoint. And that's important because you don't usually look that early to see anything, but they saw this. That's not so impressive. This is what's impressive, is they had an exploratory analysis that showed a significant reduction in death, rehospitalization for heart failure, and VAD or transplant. And the hazard ratio for that was 0.54 at 8 weeks after leaving the hospital. So arguably, if this is true, by putting a patient on sacubitril valsartan in the hospital at 8 weeks, you've saved lives. There's not very much in medicine that does that. So I urge you to try using the drug, if you can. I want to just talk very briefly about the SHIFT trial, which tested ivabradine. Ivabradine inhibits the IF, or the funny potassium channel in the heart. It slows the sinus depolarization rate and slows heart rate without blood pressure effects. So the patients in the SHIFT trial had EFs, less than 35%, not greater, and a heart rate greater than 70. This was a big trial, 3,000 patients plus in each arm. And in fact, heart rate went down with ivabradine compared to the placebo group. So they were getting the drug and it did what it was supposed to do. And it reduced the composite endpoint of heart failure, hospitalization, or death by about 18%. So it was a positive trial. The effect on death was not significant. So it was mostly a hospitalization benefit, which is shown here. The problem with SHIFT, and the reason ivabradine is not used as commonly, is that the patients were on good background therapy, so 90% of them were on a beta blocker at randomization, but only 50% of them were on 50% of their target dose of beta blocker, and only a quarter of them were actually at target dose. So the question is, if you're aggressive with your beta blockers and you get them to target dose, does ivabradine still work? And I don't think the trial answered that question, which is why this drug is not used as often. And I would urge you, if you have a patient at target daily dose and they're still tachycardic, to consider ivabradine. So optimizing therapy in heart failure, as you all know, is more than just drugs. You have to educate the patients about their disease. You have to encourage them to get physically active. You have to encourage them to reduce their other cardiovascular risks. You have to do a lot of things. And again, I point you toward this document that helps you do these things. And I want to show you some of the things it can help with. This is a table that you can't read, but it's starting and target doses of selected guideline-directed medical therapy for heart failure. So it's really useful. It gives you all the medications, what you should start at, and what you should titrate up to. Optimization of heart failure care. This is triggers for referral to a specialist or program. So if you're seeing these things in your patients, you might want to enlist the help of the transplant program here with that patient. And then this is my favorite, helpful information for completion of prior authorization forms. Like, is that the most useful table you've ever seen or what? This is a great document, I'm telling you, very practical. All right, so we've gone in a whirlwind fashion through the therapies, the drug therapies for heart failure with reduced ejection fraction. We have device therapies that are incredibly effective too, but I only have an hour. I urge you all to develop comfort treating heart failure aggressively according to guidelines and using multiple medications in your patients. You want them all to be warm and dry when you're managing them in the outpatient setting, and partner with a heart failure cardiologist for the hardest cases. You have the privilege of practicing alongside some really talented heart failure cardiologists here, and I thank you.
Dr. Sweitzer, that was an incredible grand round. Thank you very much. And I thank the Lemberg family also for being here to sponsor it. We have some time for just a few questions. Maybe I can begin by telling me how gender plays a role in the way in which you approach a patient like this in terms of treatment.
Yeah. So the studies, as we're always criticized that we don't enroll enough women in trials, and heart failure trials are not a 50-50 split between men and women, but heart failure with reduced ejection fraction is not a 50-50 split. About 30% of patients with heart failure with reduced ejection fraction are female, and most of our trials enroll about 30% women. So we're enrolling proportionally to the population with the disease. I don't think we're really under-enrolling women. We're not enriching for women. Nevertheless, there have been many meta-analyses now of ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists that show no evidence that there's differential response in men and women to these therapies. And so, at least as of our evidence today, I apply the therapies equally in men and women. Now, interestingly, in the device world, cardiac resynchronization therapy, or BiV-ICDs, or BiV pacemakers in particular, seem to work better in women than in men. And yet we apply device therapy much less often to women in practice. And so it's important that women may get a preferential benefit from that particular device. Otherwise, everything shows pretty equivalent responsiveness in men and women.
Dr. Fornoni.
Thank you, Nancy, for acknowledging.
It's good to see you again, yeah.
I have a question. You did not mention any of these SGLT2 inhibitors, and now I see it coming with empagliflozin,
Yes.
heart failure outcome.
Yes.
Can you comment on what those implications are?
I will, yeah. So the question is SGLT2 inhibitors for diabetes. I didn't talk about that, but there's really intriguing data that came out of the trials of these drugs in diabetics, sort of unanticipated. They looked at cardiovascular outcomes as a big bucket, and cardiovascular outcomes were improved by these medicines. But then when they started looking, much of that cardiovascular benefit seems to be in reduction of heart failure. There's many reasons why these drugs may improve heart failure outcomes. Not insignificantly, the mechanism of action is to keep glucose in the kidney and peeing it out, and it probably takes water with it. So they actually probably are diuretics. But there are many other molecular mechanisms that may work. So this is obviously very intriguing. I think right now the data suggests that if you have a diabetic patient with heart failure, and all other things being equal, you should probably put them on one of these anti-diabetic agents, absolutely. But there are 3, 4, or 5 trials going on now looking at these agents in non-diabetic patients with heart failure because they think the effect may be so profound to improve heart failure outcomes. And we're waiting for those trials to be released.
There was a really nice talk on Monday on cardiorenal syndrome and management, and there was a lot of discussion about early ultrafiltration rather than just keep pounding the patient with diuretics. And there was data that they presented that discussed, that you were able to better sensitize them to diuretics, reduce the risk of AKI. What's your take on pulling the trigger on early dialysis when patients come in with becoming severe heart failure?
Yeah, this was at ACC. Yeah, I was there. This continues to be a very controversial issue. The believers in ultrafiltration are real believers, and they say these things, but there's not a lot of data that what they're saying is actually true. A lot of it's anecdotal, small single-center studies, probably highly selected patients, and other people's experience with ultrafiltration has not been so good. And when you look at the ultrafiltration trials, arguably the patients in the diuretic arm weren't very well diuresed. So the comparator, there's always questions about those comparator groups. I think we need a good trial still to know. Some people say it works best in those in cardiorenal syndrome. Some think it works best in people without cardiorenal syndrome. So that right there tells you we don't really know. So I think that when you have, one of the things about volume overload is if you have a lot of venous hypertension, you are reducing the gradient for flow through your kidneys, right? Venous pressure is getting up toward mean arterial pressure, and you don't have good renal blood flow. That's probably a very bad situation. If you're unable to reduce venous pressure with good therapy and the kidneys are getting worse, then you probably I don't know if you probably should That it's not unreasonable to try ultrafiltration to get venous pressure down, though. That's what you're really trying to do, as long as you have that as your goal.
In the acute setting, obviously.
In the acute setting, yeah, you can't ultrafilter heart failure patients in the outpatient setting.
Barry.
Thank you very much for this excellent lecture. Torsemide was just, it's an excellent drug. The manufacturer didn't know what they had, and they just never marketed it. But a question, enalapril is a relatively short-acting ACE inhibitor. Have any of these trials been done with either BID enalapril or with longer-acting lisinopril?
So all of the enalapril trials in heart failure use at BID. And interestingly, the best data in heart failure is with enalapril. Lisinopril's never been tested in a non-ischemic population. There was an ischemic cardiomyopathy trial, but it excluded non-ischemic patients. There's one small trial with ramipril, but essentially all the data is in enalapril. If you want to be a truly data-driven physician, enalapril is your ACE inhibitor of choice. It's generic, twice a day, right?
Thank you.
Dr. Hare, you want to make it?
Let me take off my microphone here.
Nancy, thank you so much for a really wonderful presentation and your cardiology grand round this morning as well. As a heart failure doc myself, I never get tired of looking through those trials. It really is it's a wonderful story of how we've made such a difference in a very serious condition over decades. So I'd like to take this opportunity to present you with the plaque for being our 27th annual Miriam Lemberg Professorship for Cardiovascular Disease. And if I could ask the Saltzman family to also come up, please. Roy, can you join us for a picture? Sure. Let's move over here.
Thank you, everybody, for coming. See you next week.
Could we have the slide turned off?
Dizzy.